Welcome back once more. So we left off at scaling, root planing, and curettage, and we talked about how a smooth root surface is easier for the patient to keep clean, unlike a tooth surface that has a lot of calculus on it, and then it was poked and prodded by the scaler and the curette, and it's left with little gouges in it. So the curette is going to actually plane it and get it to be smooth and able to be free of those areas for the plaque to continue to build. And let's advance here. Okay, so here is a look at a scaler going into the area. Actually, it's probably curette that's going to go into that sulcus and clean out any subgingival debris. Scaling. So scalers are used to remove supragingival calculus from the tooth surface. Curettes are used to remove supragingival and also subgingival calculus, mostly subgingival calculus. Some areas on the root surface may remain rough after the calculus is removed. This is because the cementum has become necrotic or because the scaling has produced grooves and scratches in the cementum. Root planing is then performed after the scaling procedure to remove any of those remaining particles of calculus and necrotic cementum embedded on the root surface. And once the planing is completed, the surfaces of the root are smooth and glass-like to resist new calculus formation, which is easier for your patient to keep clean. When we perform gingival curettage, this means that the soft tissue is scraped or cleaned with a curette. Some patients will also require gingival curettage in addition to scaling and root planing. This curettage is also referred to as subgingival curettage, which is the scraping of the gingival lining of a periodontal pocket. It's performed to remove the necrotic tissue from the pocket wall. So here's a look at what happens during scaling, root planing, and curettage. So your patient presents, and this gray matter here is calculus. And this patient has a really deep periodontal pocket. So that means that they have to bring their toothbrush and their floss all the way down to the very end of this, which is probably a 6 or 8 millimeter pocket in this case. So this tissue is a big turtleneck that's surrounding the patient's tooth. So we have the crown of the tooth, we have the cementum, and then the dentin underneath. So in scaling, we remove the calculus. When the scaling is performed, calculus is removed. Now we have this kind of wide open, flappy piece of tissue that's here. Then we have some kind of irregularities that are on the side of the cementum. The hygienist will take their instrument and file or run their curette over this to make it smooth. And you can see that there is less cementum now than what once was there. But we also need to take into consideration all of this inflammation, this dead and diseased tissue may need to be removed in order for the tissue to finally be able to heal. So that's where they take the end of their curette also and remove all of that diseased tissue. So now we really have a flap of tissue here for the patient. We have a clean, smooth surface, and hopefully if they're given proper instruction on how to clean their new area and maintain it, that it will not reform the calculus that was there. We can also place in those large areas of pocket an antimicrobial and antibiotic agents to help heal and keep the bacteria at bay. So tetracycline is an antibiotic that is particularly useful for the treatment of periodontitis. Also for early onset periodontitis and rapidly destructive periodontitis. So we'll talk about those in our next lecture. Penicillin is less effective against periodontal disease than any other antibiotic because many perio pathogens are resistant to it. So many times the patient does have infection around their teeth in their gums, some doctors will prescribe a systemic antibiotic, but it will not be penicillin. Fluoride mouth rinses have also been shown to reduce bleeding by delaying bacterial growth in the perio pockets, which is very promising. And we can also prescribe a twice daily chlorhexidine rinse as the most effective means available for reducing plaque and gingivitis. The only downfall with chlorhexidine is that it can stain the tooth structure and some composite materials brown. For locally delivered antibiotics, so these are medications that are not swallowed and metabolized by the body, these methods can now be used to apply antibiotics directly into the periodontal pockets. So in one technique, a fiber which contains tetracycline is packed into the pocket that has not responded to any other method of treatment. Other methods include using a syringe to insert dissolvable material such as a gel into the pocket, which uses a doxycycline antibiotic, and in another technique, there is a dissolvable chip that releases chlorhexidine inserted into the deepest portion of the pocket to treat that microbial action. When other non-surgical treatment is ineffective in stopping the disease process, periodontal surgery is indicated to control the progress of periodontal destruction and further loss of the attachment. So advantages of periodontal surgery: the primary advantage is that it allows access to the root surface for scaling and root planing. Surgery makes it easier for the patient to clean those difficult areas, and periodontal surgery also results in better access to furcations and other areas that are difficult to reach during the traditional scaling and root planing. So if you think back to that illustration that I showed of scaling and root planing and curettage, that big flappy sulcus area, the pocket, is going to still be deep. It's still going to be hard to clean, and it's still going to be a very big catch-all for bacteria, food particles, and material to just live there and ferment. So if we trim away some of that turtleneck around the teeth, it allows patients to have a little bit more control over their hygiene. Disadvantages of perio surgery is we need to take into consideration the health status of the patient or the age of them, and also take a look at their limitation of the procedures and how the patient is able to manage the wounds after the surgery is completed. We need to take a look at this from the patient's point of view, and the disadvantages of surgery are going to take a lot of time because it's going to be a long procedure. It's going to cost a lot of money. It's going to be a substantial investment for them. It may goof up their aesthetics that they have and not make them quite, make the teeth look longer. It could certainly make some crowns that were placed look out of place if they are porcelain piece of metal and see the margin of the metal in the porcelain. And it's definitely going to cause your patient discomfort. I would not wish periodontal surgery on anyone, to be honest. The dental assistant usually has developed a good rapport with the patient, as in a unique position to discuss these concerns with the patient and hopefully try to quell any fears or trepidation that the patient may have. We also need to take into consideration the remaining bone that the patient has as a source of support for the teeth. So the amount of bone remaining around the tooth is an important consideration into the decision to perform perio surgery. When large amounts of bone are around the tooth, the dentist may take a wait-and-see approach, postponing or even avoiding periodontal surgery. With this approach, though, the patient must practice excellent home care and routine dental care. If the amount of bone is already reduced, though, delaying the surgery may drastically lessen the chance of saving the patient's teeth. We are going to use the following items to help the dentist assess the amount of remaining bone around the teeth. So we're using those periodontal probes, 6 measurements around the teeth. We're going to be using the radiographs, the periapicals, and the bite wings. We're going to also be looking at what those probes are gathering data as far as the bleeding index, the mobility of the teeth, any exudate or pus that's present upon probing, and also the recession that is present. So here we have a tooth in cross-section and looking at the amount of attached tissue around the teeth. So we have 7 millimeters of tooth in the attachment. Here we have only 5 millimeters of tooth in the attachment, and here we have 2 millimeters of tooth in the attachment. So in this case, very little mobility should be present. This case, there may be a class 1 mobility. In this case, there may be a class 2 or class 3 mobility where there is a lot of tooth out of the soft tissue, or it's only being held in with soft tissue. There is no bony attachment here left at all. And if you can remember the analogy of the fence post, when we have more of the post out of the ground than in, it does not make for a very sturdy post. With advanced bone loss, surgery may be performed in an effort to save the tooth, but the prognosis is usually poor. The basic measure a patient can use to prevent this type of bone loss is to have regular dental checkups, professional cleanings, brushing well twice a day, not brushing hard, but brushing well, and cleaning daily between the teeth with flossing and eating a well-balanced diet. When we talk about surgery, we can talk about a few different types. The first is excisional periodontal surgery. This type is used to remove excess tissue. It is the most rapid means of reducing perio pockets. We have gingivectomy and gingivoplasty are the common types of these excisional surgeries. A gingivectomy is the surgical removal of diseased gingival tissues. This procedure is performed when it is necessary to reduce the depth of perio pockets and when fibrous gingival tissues must be removed. The surgical procedure involves making bleeding points with the use of those pocket markers and also removing the gingival tissue with periodontal knives such as that Kirkland knife and Orban knife and with scissors. In a gingivectomy, recently the use of dental laser equipment in gingivectomies have become popular. And after healing with this type of surgery, it's easier for the patient to clean in which the pockets have been reduced. Here we see some photos of the gingivectomy. So we're using a Kirkland knife to remove a lot of this overgrown excess diseased tissue. You can see how puffy and just unhealthy this looks. Some scaling and filing of the tooth structure, and then here is a post-op photograph of the result. Here we have some gingivitis. We can see kind of purplish puffy gums. The tissue was removed, and here is a nice, very aesthetic result following the procedure. Gingivoplasty, though, involves the surgical reshaping and contouring of the gingival tissues. The presence of deep perio pockets with fibrous tissue is the main indication for both gingivectomy and gingivoplasty. Often, these procedures are performed simultaneously, and during gingivoplasty, the gingiva are recontoured with the use of periodontal knives, actually rotary diamond burrs, curettes, and surgical scissors. The gingival margins are then thinned and are given a scalloped edge. So here we have gingivoplasty, and we have swollen, inflamed gum tissue. Here's the result after the procedure. And in this picture, I wanted to show you, you can see how the tissue kind of looks abraded. And this was done by a rotary burr, a diamond burr, to remove and reshape this tissue. And here is the result post-operatively. So thing to remember is that a gingivectomy is the removal of diseased gingival tissue, and gingivoplasty is the reshaping and contouring of those gingival tissues.